The last case presentation by Dr. JYOTHI. Dr. JYOTHI KRISHNAN currently works in Little Flower Hospital, Angamali. She had done her undergraduation from Trivandrum Medical College and post-graduation from Calicut Medical College, and she had finished a long-term cornea fellowship from Little Flower Hospital, Angamali. She will be talking about the corneoscleral laceration, that is the corneal trauma. And after that, we will be having the much-awaited talk of Namrata Madam. Thank you.
Good morning, everyone. First of all, I'm sincerely thanking Dr. Anita Madam for this opportunity. Let's come to topic. This is a case of a bilateral corneoscleral laceration with a visual axis involvement and journey of visual rehabilitation. So this is a story of a 40-year-old male who met with an accident, auto versus truck, and the windshield was broken and glass particle fell into his eyes. So the patient initially assessed for any brain injury or fracture, and there was no significant trauma. Hence the patient referred to ophthalmology casualty for evaluation. The initial photos were not available as the patient comes to casualty. So this is a diagrammatic representation. The patient, there is a right eye, there is a large corneoscleral laceration extending from limbus to limbus with the iris prolapse. And the vision is only hand movements. Hyphema was there, lens not visualized, and there was also multiple lid laceration. And the left eye, there is a large central stellate full thickness corneal laceration with a cataractal subluxated lens and multiple lid laceration, and vision is only CF at 1 meter. So the patient was admitted, and under broad spectrum antibiotic and steroid coverage, the corneoscleral and entire repair done on 74/25. And CT orbit taken, there is only hemorrhagic choroid detachment. Luckily, there was no intraocular foreign body. So this is a post-op day 1 picture of right eye and left eye. The sutures were intact and the AC was formed. And there is a independent cataract in right eye. And we did a B scan to assess the posterior segment and shows right eye the resolved hemorrhagic choroid detachment and left eye was normal. And during the follow-up, as he is a young patient, with the lack of vision, he became very depressed, and we did a brain and mind clinic consultation and appropriate treatment and counseling given for the patient. So we did the primary closure. Now the rest of the treatment is pending. So we have to plan on suture removal, cataract management, and IOL implantation. So for the right eye, there is a cataract is indomescent, but the AC is maintained. So we can wait till the suture removal and plan an accurate IOL calculation and cataract later. But in case of left eye, the ruptured lens capsule supranasally, and the cortical matter is exposed and the shallow AC, and IOP is also getting high. So we did a lens aspiration on 28/25, that is 12 days after the initial repair, and we planned for a suture removal and IOL implantation later. So this is the left eye after IOL lens aspiration. So after 4 weeks, we did a partial suture removal. That's the first picture. And after 6 weeks, we did the complete suture removal for the right eye. This is a video of suture removal. So the left eye after complete suture removal. So the stepwise suture removal was done. So next is challenging is the IOL calculation. So that is even after suture removal, that is a highly irregular cornea with irregular astigmatism. So the K1, K2 is not getting with the conventional method, that is not accurate. So the IOL calculation became a challenge. So the pentacam became our savior. We did a pentacam and we extract the Hollada EKR values for the irregular cornea. So the Hollada EKR values that is, give an improved estimation of true corneal power by incorporating posterior corneal curvature. So the reducing error in IOR calculations. And there is no single EKR zone is universally superior. So we took 2 mm readings, but we have to individualize the selection, and based on topographic regularity is also needed. So this is the Oculus Pentacam Hollada EKR detailed report. We can see that the multiple zones are there, and we took the 2 mm zone values, that is estimated K1 and K2. And this value is incorporated into IOL master, and the correct IOL calculations were done. Then we have to assess, before IOL implantation, we have to assess whether the patient has visual potential or not. For that, we did a RGP trial. So the RGP provided best visual acuity by neutralizing the anterior corneal irregularity and making the regular cornea astigmatism and allowing regular refractive surface. So RGP over refraction is a reliable predictor of the patient's visual potential before planning a definitive visual rehabilitation. And in our case also, that is eye with trauma. So in eyes with the post-traumatic scarring and topographic distortion, RGP trial differentiates the optical limitation from two retinal and neural deficits. So we did a right eye lens aspiration plus IOL done on 36-25 and 2 weeks after complete suture removal. This is the post-op picture. And left eye suture removal done after 12 weeks. That's a stellate wound. So after 12 weeks we did a suture removal. And RGP trial was done and left eye secondary IOL done on 25-8-25. So this is a video. You can see the corneal edema still persisting even after suture removal and lens scar. Surgeon Dr. Anita Jabba. The posterior capsule was adherent to the sulcus and iris, so that adhesion is also released. And a 3-piece foldable IOL is implanted. An IOL was placed in the sulcus. So after that we move on with the further visual rehabilitation. So first we tried a RGP trial, but the patient is not comfortable with the rigid gas permeable lenses. So we move on with the miniscleral contact lenses. This is the patient's left eye with the miniscleral contact lenses, vision improved to 612, and this is the right eye, vision improved to 69. But with the bilateral corneal trauma, scarring, he is very reluctant to use the scleral contact lens. So he said it's very difficult for him to put the lens. So he discontinued the lenses and so give spectacle correction. With the +5 D square, his vision improved to 618, and +3 D square, his vision in left eye improved to 680. So challenges in this case are this is a bilateral corneal tear in a young patient who is only 40 years old, and the visual axis in both eyes are involved, and the lenses are already cataractous and subluxated and with a highly irregular astigmatism, and the timing of suture removal and planning of iris surgery and visual rehabilitation become a challenge. So the key points in this from this case are there's a crucial timing for cataract extraction and suture removal. You have to judiciously wait and watch for the suture removal and cataract extraction, and the use of different modalities for K1, K2 measurement, like in irregular cornea, with multiple modalities there, and we did a EKR value, and that is become very accurate. And to assess visual potential, we can trial RGP and the scleral contact lens for further visual rehabilitation. So we must never give up on a corneal trauma. Our commitment to preserving and restoring vision demands that we continue to striving for better outcomes. Thank you.
So thank you, Jyoti, for that